My talk today is on breast ultrasound. Thank you, Amina, for the wonderful introduction and for the opportunity to speak with you guys. So the outline of my talk is going to be going over basic anatomy for breast ultrasound, some basic physics and why it's important, some technique to hopefully optimize your imaging and to make you better interpreters. And then the largest sections of my talk will be on evaluating symptomatic women and reporting using BI-RADS or condensed BI-RADS. And hopefully by the end of this talk, you will understand why it's important to have a systematic approach to doing breast ultrasound. So first, anatomy. So when you place the transducer on the skin of the breast, you should see all the way through the entire breast and the beginning part of the chest wall. I have included the lung at the bottom of the image just so that you can see the different parts. So the dermis that you can see goes from where your transducer touches down to this white stripe here. Although there are parts that actually go beneath this white line, which you cannot see. These are suspensory ligaments. These are white lines that go through the adipose tissue. You'll notice in this image that it's nice and flat, which means you're giving good compression. If you lightened up on compression, these would extend up to the skin surface, and they cause artifacts. These suspensory ligaments are what give the breast its shape. And as one ages, they become a little bit more relaxed, and that further changes the shape of the breast. This is an intramammary lymph node. It has an echogenic hilum there with the bottom arrow, and the cortex, which forms a C, shown by the top arrow. Then there's the pectoralis muscle and ribs there in the middle, and followed by the lung. It's very important that you understand that the ribs will be touching this white line, which is the pleura of the lung, because they look like scary masses, but how you distinguish them is where they're located in relation to the lung and the pectoralis muscle, which means the ribs. And if they're superficial or closer to the transducer, they represent masses. So moving on to ultrasound physics, before I do, does anybody have any questions with anatomy? I can't see any faces or anything, so feel free to speak up.
Yeah. So in case someone has a question, you can always type in the chat or raise up your hand. We'll be able to see you and unmute you. Thank you. I guess there are no questions. We can go ahead.
Okay. So ultrasound is a mechanical energy that travels through tissue as a wave. And these high pressure waves and slow pressure waves are what cause the characteristics that are then transmitted back to the probe and form an image. It should be noted that medical imaging uses a frequency between 2 and 20 megahertz, even though anything over 20 kilohertz frequency is considered an ultrasound wave. In breast imaging, we're exclusively talking about the high frequency transducers, so typically above 10 megahertz. This is there's 2 slides that are a lot of physics, and I apologize for that, but there are a couple things that I wanted you guys to learn. First is the axial resolution, or the ability to resolve 2 separate reflectors or masses or objects that are located parallel to the beam. So if the transducer is placed on the skin and you have mass 1 and mass 2, your ability to resolve both those masses as 2 separate masses are related to the velocity of speed of sound and the pulse duration. And you can resolve these 2 by increasing the axial resolution using a higher frequency transducer. So going from 10 to 12 megahertz, for example. And that should be separated or distinct from lateral resolution, which is the ability to resolve 2 masses that are located next to each other, perpendicular to the beam. And this is the function of the beam width or the transducer design. So it is difficult to resolve this, but you can do better by locating the focal zone at or below the level of interest. And I'll get into the focal zone a little bit later. So the next part is the technique. And I don't see any hands up, so I'm going to continue going. Hopefully I'm speaking slow enough for people to follow along. So I'm going to go over specific things and about how to optimize your room and your exam for the patients, because if you're seeing multiple patients a day over periods of time, you can actually develop problems. And so I'm going to teach you hopefully ways of optimizing patients and how you hold the transducer so this doesn't happen to you, and also your pictures come out better. So bed positioning, if you can raise or lower your bed, the bed should be approximately at the waist height so that the examiner's arm is comfortable while scanning. It prevents fatigue and injury, but just remember that you should lower the bed when you leave the room so that patients don't fall off the bed. Here's an example of me scanning a patient, and you can see that on the left-hand side, the bed is too low and it forces me to kind of stretch my shoulder. Now, if you're only imaging one patient, that's not that big of a deal, but over 20 to 40 patients a day and doing it 5 days a week, this can really cause problems. And so the picture on the right shows the appropriate bed length. You can see how my elbow is just slightly bent beyond the a right angle. That also means that the patient can see the images too, which many appreciate. So patient's positioning, proper positioning of the patient and transducer is essential. It's, you want to use the probe to compress similar to mammography. It should be positioned to create a uniform thickness in a block of tissue. So that means that the chest wall should be parallel to the bed. So it can sometimes help to roll the patient up on her side or at a 45-degree angle so that the breast is kind of sitting on the chest wall and not in the armpit or flopped over onto the other side. In general, we use wedges or pillows to prop up the patient if we're looking at the lateral breast or the outside of the breast. And we usually do not use it when we're evaluating the medial part or inside of the breast. But there's a lot of factors that might change that rule. Here's an example of a wedge. And you can see that it is placed underneath the patient so that she's at a 45-degree angle and her breast is now just contained on her chest wall. It doesn't move over to the left side or into her armpit. Here is from the other side, showing how her breast is on the left picture is actually off to the side. And so there's not a lot of tissue where I'm imaging, and that's compared to her being rolled up on the right side, where you can see that the breast tissue thickness is consistent all the way around her breast. So the picture on the right is correct. So how does this affect ultrasound pictures? So we saw how it affects the outside of the patient. Now how does it affect the inside of the patient? So on the picture to the left, the patient was not on a wedge, and you can see that the chest wall is not uniform, so it's coming at an angle. And so maybe about 15 to 20% of the picture is of the lung. Yet on the left picture in the left corner, you can see that you're missing some breast tissue. The breast tissue is actually deeper. So you're not imaging the entire breast tissue where you're looking. You might be missing something. Now compare that to the right image where the chest wall is nice and level. You can see the top of a rib, and you can see the pectoralis muscle, but you're not missing any breast tissue. So including the lower part of the top part of the pectoralis muscle and the rib shows the person who's looking at the image that you have included the entire breast tissue. So the one on the right is better. That's the focal zone, and I'll get into that in a second. But that shows you that the focal zone here is going across the fibroglandular tissue, the white tissue, which is what you want because that gives you better resolution. Transducers should be held parallel to the bed. So the bed should be parallel to the chest wall, and that should be parallel to transducer. Pressure should be uniform and sufficient to see through the entire breast, and you want to hold the transducer at its base. Let me show you an example. So the picture on the left has me holding the transducer at an angle. Now you can imagine that if you are taking a picture of that and you give a clock face that it's at 12 o'clock, your finding may actually not be at 12 o'clock. It may be at 6 o'clock because of the way you're holding the transducer. On the right side, you see that I'm holding the transducer correctly. I have one finger on the breast so that I have control and stabilization of the transducer. I'm holding it at the base, and I'm holding it, the transducer perpendicular to the breast, or the transducer plate is parallel to the chest wall and parallel to the bed. This is important. Here's another example of an incorrect positioning. You can see on the left picture, I am holding the transducer by the cord. Some people do this because they find it more comfortable, but the problem is that as you turn, you're going to loosen the cord from the transducer, and that's the most expensive part of the cord. The other thing that you'll notice here is that without a reference point, for example, having your pinky on the breast, when you're focusing on the screen, trying to interrogate or look for findings, you're actually may not be scanning the breast. You may be up in the thyroid, you may be on the other breast because you're not paying attention. So having that pinky as a reference point on the skin while you're holding the transducer at the base perpendicular to the breast tissue or parallel to the chest wall allows you to be watching the screen and looking for changes while you're moving the transducer. Here's an example of transducer pressure that we talked about being uniform and sufficient to see through the entire breast. We talked about Cooper's ligaments or suspensory ligaments, and you can see on the picture on the left, the Cooper's ligaments or suspensory ligaments go straight up towards the skin surface. And what you can see is that causes artifact, the shadowing that goes through the breast tissue. And the edges of the fat and fibroglandular tissue also look blurry. That's because of these incomplete compression. And to contrast that, look at the picture of the same area on the right picture with adequate compression. The interfaces between the fat, which is gray, and the fibroglandular tissue, which is white, is very crisp and clear. The suspensory ligaments are nice and flat. And so you can see the transition between the adipose tissue and the fibroglandular tissue. You can see the pectoralis muscle, and you're not getting shadowing as artifact from the suspensory ligaments. Okay, so now that we've positioned, we're holding the transducer correctly. Now we're going to go over how to adjust the settings on the ultrasound machine so that you can acquire beautiful pictures and make interpretations. So depth should be just enough to catch the chest wall so that the person looking at the images know that you have the entire breast. If you look on the left side, the left picture, you can see that half the image is taken up by the lung and the chest wall. This is too much depth, so you have to reduce the depth. On the picture to the right, you can see that there is proper depth. Just the top of the chest wall is visualized, but most of what you see is the area of interest, which is the fibroglandular tissue in white in the center of the field. Next is focal zone. I will tell you that modern ultrasound machines do not have focal zones. I don't know why. The machine automates that. And so depending on the ultrasound machine, you may not have a focal zone. So if we look in the upper left-hand corner, you can see these 2 hourglasses, which is the focal zone in this particular machine. And there's 2 of them, and they're located in that pre-mammary fat. Now, if you're looking for something in the pre-mammary fat, this might be acceptable, but typically you're looking for the fibroglandular tissue, so you should move these focal zones down so that it is covering the fibroglandular tissue, as shown in the lower left-hand corner. Lower left-hand corner has the 2 hourglass focal zones covering the fibroglandular tissue. And that's correct. So that's what you want. In the upper right-hand corner, you can see that they only have 1 focal zone. And even that is, so they should have 2 because of the size of the fibroglandular tissue. But even then, with a single one, you're not getting any coverage of the breast tissue. So they need to either move this focal zone up towards the fibroglandular tissue, but preferably they would add 2 focal zones. Now contrast that with the lower right-hand corner, where they basically made the entire image a focal zone. So the focal zone is where your high-quality ultrasound beam is, and you want to make sure that that's limited to the area of interest so that you have more high-quality ultrasound images. So I want you to take a look at these 4 images and look at the quality. This is the same ultrasound machine, and all we've adjusted is the focal zone. And hopefully that you see that quality-wise, the lower left-hand corner photo is has better quality. You can see the milk ducts, you can see the interface between the fibroglandular tissue and the adipose tissue. And so if there's anything there of interest, you would find it. Okay, last is gain. So gain is the brightness or the darkness of the image. And you can see that optimally what you would like is the breast tissue, the fibroglandular tissue to be white, but not bleached white. And you would want the adipose tissue to be gray, but not dark black gray. So in the upper left-hand corner, you see that the adipose tissue is really dark and you really can't see anything inside it. So the gain is too low. And that's contrast with the upper right-hand corner where the gain is too high. You could see the fibroglandular tissue bleached white, and there's no way you're going to find anything like cancer in that fibroglandular tissue. The proper gain is in the lower picture where you can see that it's like a light white for fibroglandular tissue and it's a light gray for the adipose tissue. So just to conclude this, you always adjust in this order: depth, focal zone, gain. The reason you do that is because if you start with gain and then change depth, you have to readjust the gain. So always go in this order: depth, focal zone, gain. Okay, next is spatial compounding. It's a method to obtain sonographic information from several different angles and to combine them on a single image. It reduces speckle artifact, it improves definition of tissue, and it makes pictures look very beautiful. However, it can also turn hypoechoic masses into cysts, and I'll show you a couple of examples. So let me show you the benefit of it. You can see that in the left-hand corner, there's a picture of a mass there, and you're not sure what it is. It looks like it could be anything. This is a very poor quality image. But if you turn on compound imaging, you can see that now that finding looks like a simple cyst and can be ignored. And you can see all this speckle artifact, which are these dots that occur throughout the image. When you turn on compound imaging, it smooths out the picture really nicely. However, you have to be very careful. So it can turn a cyst into a beautiful cyst, and that's shown here in the left-hand corner. But when you use it and you're not careful, it can turn triple negative breast cancers or other masses into what might appear as a cyst. So in the right-hand corner, that's actually cancer. But if you look carefully, compound imaging did not really make this into a cyst. This is not completely anechoic on the inside or black on the inside. There's some hypoechoic areas that you can see that should tell you that this is not a simple cyst, that there's something else. Now, it could be a cyst, it could have debris in it, but you can't let the finding in the right side go without addressing it. Whereas on the left side, because it's a cyst, you can let that go. Okay, a couple more things about image quality, and that is labeling. It is very important to label things consistently. There is a standard that we use, and that is a clock face and distance from the nipple. We always label it as right breast, 3 o'clock, 7 centimeters from the nipple, trans or longitudinal, etc. We don't put 3 o'clock right, 7 centimeters from nipple, breast, or 3 o'clock, 7 centimeters from nipple, right breast. The reason the convention is to do it in this order is that older ultrasound machines don't allow you to change individual words. They force you to delete the entire sentence. So if you put 3 o'clock first and then 7 centimeters from the nipple and then right breast and then trans or longitudinal or whatever you put at the end, in order for you to change the 7 centimeters from nipple or 3 o'clock or trans to longe, you have to delete the entire sentence, and that just becomes very cumbersome. So it's better to stay with this convention because it will help you label things consistently, not forget to put certain things on the description of where the finding is, and it also helps you not have to retype things. We use the clock face as if you're looking at the patient. So 12 o'clock is always superior towards the head and 6 o'clock is always towards the feet. But then it goes along the clock face so that 3 o'clock is a medial breast for the right side, but it's the outside of the breast or lateral aspect of the breast on the left side. And the distance from the nipple is actually the distance from the nipple, not the edge of the areola. So you should be measuring from the actual nipple, not the areola. Okay, how do we properly measure masses? We always use centimeters, even in the US, which it's hard to imagine. We still do not use centimeters here. But for breast imaging, we do use centimeters. We take 3 measurements of masses. We do 2 in the trans direction or radial direction, and 1 in the longitudinal or anti-radial. Now, it's important that you use a convention in Uganda that is consistent. So if people at Malago Hospital, for example, use trans and longe to get 2 different pictures of each mass, then everybody should be using that at Malago Hospital. The reason you do this is because if you're following up a mass and one person uses trans and longe and the other one uses radial and anti-radial, you might actually be getting different measurements, and that can be hard to follow up masses. There's a couple of artifacts I want you to be aware of. First is edge shadowing, which is caused by the bending of the ultrasound beam at the interface of 2 dissimilar tissues with different sound velocities. So you can see that, previously we showed that without proper compression, you can have edge shadowing at the suspensory ligaments, but you can actually have it at the transition of masses, fat lobules, and cysts, because the beam is being bent away from the object. And it's shown here with these 2 yellow arrows. You can see the shadowing. How do you get rid of this? Well, you just press down harder, or you angle the transducer a little bit so that it's not, the artifact becomes less. So by pressing down harder, it kind of flattens the surface, so it makes it less of an abrupt transition. Next artifact is a reverberation artifact. It's caused by repetitive reflections between 2 highly reflective layers, so like simple cysts. You can tell the difference because they're equally spaced bands of diminishing amplitude. So you can see here in this figure, you could see the reverberation artifact where you see 2 or 3 lines that are straight. And if you see that, it tells you that it is a cyst. You can change the gain. You can change the angle to try and reduce these, but typically we just let them go because they're a good sign that there's a cyst. There's the reverberation artifact. Through transmission, this is actually a useful artifact. You can see that in the picture on the left, there's increased through transmission or enhancement, and that's indicative of a cyst, but it can be caused by necrosis too, so you can't use it as a sole characteristic to decide what is a cyst. Similarly, you see edge shadowing on the right picture, and that's caused by a cancer. Does anybody have any questions about physics or technique?
Members, if you have questions, kindly you can type in the chat or you can raise up your hand. If we don't have any questions yet, we can go ahead.
Okay, we will continue. Okay, so now that we have the patient and we know how to position them, we know how to take good quality images, now I want to go over how you approach a patient and how you decide what exam is appropriate. Sometimes when a patient comes, they have clinical information like a clinician felt a breast lump or the patient feels a breast lump. And it's important that even though people may not be taught this in sonography school or radiography school or radiology school, that you actually take a good history and perform a physical exam. This clinical breast assessment is critical for deciding what to do. For example, if a patient comes to you and says, I have a mass and it's located in my left breast and I never felt this before and I'm good about checking, it's something that should play in your mind that this is something more serious. But if they say, you know what, I felt this mass, I felt it hasn't changed in 2 years, but I decided to get it checked because I was in town, you might treat that a little bit differently from a clinician standpoint, even though breast imaging silos you into just focusing on the imaging. Ultrasound is better when you do it focused on the palpable or symptomatic area rather than just scanning around. But it depends on whether the patient's there for multiple symptoms or regional symptoms, and I'll get into that in a little bit later. Then after you look at the symptomatic area, you optimize the imaging. So adjust depth, focal zone, and gain like we went over to optimize the visualized area. And then you properly label the location on your imaging. And then you do proper measurements. And then you acquire pictures in 2 perpendicular planes, either trans or longe, or radial and anti-radial. So if you have a mass or a cyst, you should have 5 pictures because 1 picture is just the mass. And then the second picture is the mass with a measurement. And then the third picture is in the perpendicular plane without measurement. And the fourth is in the perpendicular plane with measurement. And the fifth is with blood flow. So 5 pictures for a mass or a cyst. If you just see normal breast tissue, 2 pictures is sufficient, 1 in each perpendicular plane. So typically for symptoms, most women present with pain, followed by lump, nipple discharge, and skin changes are relatively uncommon. The prevalence of pain in a population for breast pain is between 70 to 80%, so it is very common. In one study that we did in Uganda, we found that very few women present for a breast ultrasound with pain. And we think that that's because there's so much going on in a woman's life that they don't have time or money to just spend on an ultrasound for something that's pain. And that's good because pain is very uncommon symptom for breast cancer. It's only when the breast cancer gets very large and that it is associated with pain. So we use appropriateness criteria, and we are working in Uganda to develop breast health guidelines that are based on these, but specific for the Uganda setting. But I thought I would share these with you so that you guys would be able to see that ultrasound is actually not indicated if it is pain that is non-focal and cyclical. It's really just the clinically significant focal non-cyclical pain that is indicated for ultrasound. Now, in the US, we have 40 years as a cutoff for using mammography and ultrasound, but mammography is often not available in Uganda and sub-Saharan Africa, and so ultrasound by itself is usually the only imaging modality that is performed, and that's okay, particularly for pain, because again, if pain is associated with breast cancer, Usually you would be able to see a mass associated with it and be large. Not 100%, but usually. Okay, so I was asked to put some questions in. So a primary care physician calls regarding a 30-year-old woman who presented with a 7-month history of cyclical bilateral diffuse pain and a negative clinical breast exam. What is the most appropriate recommendation? Diagnostic mammogram, screening mammogram, ultrasound of both breasts, reassurance, breast MRI. Reassurance. Again, cyclical diffuse breast pain is not an indication for a breast ultrasound. Here's another question. A 40-year-old woman presents with a 3-month history of constant focal breast pain in the right upper outer quadrant. Clinical breast exam is negative. What's the next most appropriate step? So in a 40-year-old, the change is that now she is eligible for screening mammography, but she now has symptoms. So you can't get a screening mammography or screening test in someone who has symptoms. You get a diagnostic test. Now, in the US, we start with mammography because she is 40 years old. But in Uganda, you would likely start with ultrasound and only move to mammography if it was available. Okay, moving on to lumps. This is the most common presenting sign of breast cancer. However, most lumps are benign and don't need to actually worry the patient. However, palpable breast lumps are associated with breast cancer in 5% of women, so you can't just ignore them, even if they look like fibroadenomas. Cysts cannot reliably be differentiated from masses on physical exam, and so if on physical exam a provider feels a mass, they should send them for ultrasound and let the ultrasound decide whether or not they're cysts or masses. So for a mass, if they're less than 40 years old, ultrasound alone is appropriate and acceptable. As we discussed earlier, as soon as they become 40, typically they start with mammography if it's available. If it's not available, then you just go with what you have, which is typically ultrasound. Okay. I'm going to skip this part because this is covered in the next part, which is my the BI-RADS talk, and it's important to I don't want to delve too much into mammography because many of you aren't practicing mammography. All right, so here's a 72-year-old woman taking daily aspirin, and she presents with a palpable mass. What's the next appropriate step? So the next most appropriate step would be to biopsy this, or you could choose to follow it. Now, there are a couple of things to consider when you make that decision. The first is she's on aspirin and she's most likely to more likely to bleed or have a bruise. So if there's a history of trauma, you might choose to follow this in a few weeks. But the easiest and quickest thing to do is just stick a needle into it, targeting this solid component. But this is what a hematoma looks like. You can see that the debris from the blood products is coming down, and you can see a flat line because it's coming off here. This is a blood clot in the middle, and that's the part that you would target. So now moving on to nipple discharge. There's pathologic nipple discharge, and there's benign characteristics of nipple discharge. So pathologic nipple discharge is bloody or clear, it's unilateral, it's single duct, and it's spontaneous, which means it happens without any pressure on the breast, it just comes out. Benign nipple discharge is white, yellow, or green. It's usually bilateral, multiduct, and it's non-spontaneous. So it's something that you press on the breast and it comes out. According to the appropriateness criteria that we use, we typically start with mammography because calcifications can be helpful, and mammography shows calcifications more. However, if a patient, if you do not have mammography available, then starting with ultrasound is appropriate, because we typically do ultrasound regardless of what the mammogram shows. Okay, a 40-year-old woman presents with bilateral multiduct white nipple discharge and a negative physical exam. What is the next most appropriate step? Is it a ductogram, reassurance, MRI, diagnostic MRI, ultrasound? Reassurance. So this is not pathologic. This milky discharge. Breasts are designed to produce milk. So if they produce milk, that's normal. Now, if a woman starts having spontaneous milky discharge and is not pregnant, hasn't breastfed, and is not being stimulated to produce milk, then that might be something to work up for a pituitary tumor or and get a brain MRI, but that's not something that ultrasound does. Here's a 60-year-old woman who presents with a 4-month history of an itchy, red crusting and thickening of the right nipple. She received antibiotics from her doctor and had no relief. What's the most likely diagnosis? So Paget's disease of the breast is a cancer that requires you to look by ultrasound and mammography underneath the nipple, but it is something that for a sonographer, if you're out in the community health centers or peripheral hospitals, that this might be best managed from a tertiary care center like Malago or UCI, even for biopsying. So I wanted to go over evaluating pregnant or breastfeeding women just for a second, just because it's an important population. So pregnancy-associated breast cancer is a diagnosis of breast cancer through the first year postpartum or while breastfeeding. It happens for every 1 in 3 to 10,000 pregnancies, so it's uncommon, but not uncommon enough to be dismissive. It accounts for 3% of all breast cancers. There's a higher proportion of triple-negative breast cancers, and so you have to be careful because it has a relatively benign appearance, as I showed you in one of the earlier pictures. That being said, 80% of the biopsied masses are benign, but I cannot stress this enough. They're usually, when there are cancers, they're more aggressive and more likely to be diagnosed later. So when you have a pregnant woman showing up with a lump or focal pain, you do use ultrasound. If they have nipple discharge, you'd prefer to have mammogram and ultrasound, but if you just have ultrasound, start there. You don't need to worry about breastfeeding. The x-rays don't get into the milk and harm the baby. We do not use MRI because the gadolinium can actually get into the baby. So ultrasound is important, even in this population, very important. Here is a patient who presents 3 weeks postpartum and is currently breastfeeding. And she has a 3-day history of right breast erythema, pain, and swelling. Now, that sounds like an abscess that's forming or mastitis, which is very common in this population, but this is what you see on ultrasound. Now, this could be an abscess forming. This could be, an infection brewing, but this is a mass and it needs to be addressed. So what's the next best step? Is it ultrasound, aspiration, or biopsy, a mammogram, breast MRI, or short interval follow-up? So it's a biopsy or aspiration. If you're getting fluid out and it shrinks, it might be worth putting her on antibiotics and following her up closely. But if it doesn't aspirate, then chances are you're going to biopsy this. All right, here's another woman who has a newly palpable, painless lump. What's the next most appropriate step? Is it biopsy, mammogram, MRI, or follow-up? So this is an oval circumscribed mass, and it can be followed as long as you're confident the patient is going to be coming back to you in a reasonable time for follow-up. If you don't think they're going to do that, it's probably safest just to biopsy it. But this is a probably benign mass. All right, here's another mass. Pregnant woman presents with a lump. What's the next most appropriate step? Biopsy, mammogram, MRI, or follow-up? Biopsy. This mass does not have any benign characteristics to it, except for maybe it's oval, but everything else is suspicious. You have darker areas, you have lighter areas, you have indistinct margins, and you have shadowing. So there's a lot of suspicious characteristics of this mass. Okay, so I finished the first 4 parts of the talk, and I wanted to pause there and see if anybody had questions before moving into the BI-RADS.
Yeah, we have some questions from the chat. Agnes Mahani is requesting for more elaboration on cyclical pain. And then we have Evelyn, who is also requesting to clarify on what reassurance is and what is done during the reassurance process.
So excellent questions. We'll start with cyclical pain. Cyclical pain typically refers to a woman's menstrual cycle. So the pain comes as they approach their menses, and then after their menses, the pain goes away. Now, sometimes in real life, it can come and go less frequently than that. Like it might come for 2 weeks or 2 months and then go away. And that's okay too. Sometimes if women's starting birth control pills, it becomes less cyclical. It becomes more painful when they start other medications as well. And so those are the kinds of pain that are less concerning. As far as reassurance, there are, of course, 2 people to reassure. There's the doctor that sent you the patient for an evaluation, and then there's the reassurance of the patient that nothing's going on. And really, it is dependent on developing a rapport with the patient or having that relationship with the patient that they trust that you know what you're talking about. And reassurance to know that it is very common to have pain in your breasts, particularly at certain times in your cycle. 80% of women have breast pain at some time during their menstrual cycle. And so that type of information can be very helpful in helping women understand that there's nothing wrong. It's just unfortunate part of having breast change as they go through their cycle. And it also can help to know that sometimes medication can help make the pain be less. So like Tylenol, for example, some people use Motrin or ibuprofen. And of course, it's very dependent on the individual. So good questions. Does anybody have any other questions?
Remember we told you can raise up your hand or type in the chat so that we can pick the question from there. Any questions? I think we can move on.
Looks like Paul has a question.
Okay. Yes, Paul? Paul, you can unmute yourself and ask the question.
Yes, thank you, doctor, for your nice presentation. I'm asking, how would you know that the discharge is from a single duct or multiple duct, as you would want to differentiate between benign and then malignant masses or discharge?
Sure. So sometimes, usually the woman would be able to tell you it's coming out of this part of the nipple. And that's because when they see blood or discharge from their nipple, they immediately start, checking their breast to find out what's causing it, because they typically see it on their shirt or their bra. And then if they don't know, or they say, oh, it's one side, but I don't know, then you can actually take your hands on the breast and actually move up the breast so that it actually is kind of like milking, and it can cause the discharge to come out. Now, and then you can see it coming out of one duct or multiple ducts. Now, the other reason that's important is because when you're looking for a finding that's causing the discharge, so let's say you milk the breast when the woman's laying on her back and you see it come out of one duct and it's bloody, well, then you can take your ultrasound probe and start at the nipple and go along that segment out towards the breast to try and find something like a mass that's causing that bloody nipple discharge.
Okay, thank you. Emmanuel is
Thank you.
asking.
No, you're welcome, Paul.
Yeah, Emmanuel is requesting for more elaboration on axial and lateral resolution as its applicability.
Absolutely. So sometimes when you're looking at a mass and you may not see the edges very clearly, and it may look like it might be two masses. And so I think the take-home message is making sure that the focal zone is appropriate, so either at the lesion or a little bit below the lesion, and making sure that the frequency of the transducer is turned up as high as possible to give you a clear picture. Now, when the mass is deep in the breast tissue, you're going to have to turn down the frequency because the high frequency beam diminishes very quickly as the breast depth increases, because the high frequency ultrasound beam doesn't penetrate deep into the breast as well as low frequency beam. So compression, increasing the frequency of the transducer, and making sure that your depth focal zone are perfected All of that helps improve your image quality so that you can measure the lesion. You can actually judge its shape and margins appropriately and make a good decision about how to manage it.
Okay, thank you. Warren just typed biopsy. I don't know whether that was an answer to many of the questions Prof has been asking. Otherwise, we don't have any more questions. We can go ahead. Warren, if it was a question, kindly let us know. You can type. If it's an answer, then that's fine.
Sounds good. Okay, so we're going to go over the breast imaging reporting and data system. I'm going to go over fairly quickly because this has been talked about before, and there's resources available online. But it was developed by the American College of Radiology, and it standardizes the language we use for breast ultrasound so that someone doing breast imaging in Uganda and Tanzania and UK and the US all use the same language and can communicate regardless of where the patient shows up. It also helps guide the assessment and management, follow-up, and most importantly, the outcomes monitoring. They're due to come out with a new edition by the end of this year or early next year. So right now we're on the 5th edition, but soon it'll be the 6th edition. Ultrasound, BI-RADS was introduced in 2003, and they developed lexicon or descriptors that facilitate assessment of the likelihood of malignancy, and I'll go over what that means in a little bit. So key BI-RADS components are terms to describe lesions, which are called lexicon, terms for assessment and associated recommendations, and guidelines for follow-up and outcomes monitoring. This is commonly referred to as the medical audit. This is often an overlooked part of the BI-RADS, but here is the structure of a ultrasound report. It's important that, particularly in countries where BI-RADS is considered standard of care, like Uganda and the US, that you use this standard template for reports, because that helps the surgeons and the oncologists and the primary care doctors know where to look for the part that they're interested in. So BI-RADS has a lot of terms and definitions for describing things. And here is a list of them. So you have shape, orientation, margins, lesion boundary, echo pattern, posterior acoustic features surrounding tissue. For those of us who only do breast ultrasound, it is important to have a very nuanced grasp of BI-RADS. However, most countries, there's not specialists that just do breast ultrasound or breast imaging. And so mastering this level of detail, and here's the second group where you have calcifications and special cases, etc., and then vascularity and assessment and management. You can see that you don't have the time to have this level of detail for every aspect of ultrasound that you practice. And when I first started working in Uganda, we looked at the breast imaging reports and we found that people were not using it effectively. They mixed terms up and they were using terms incorrectly and sometimes just made up terms. And this is expected, again, because the person performing ultrasound performs ultrasound of all different body parts and shapes and disease processes. And so again, when you're handwriting reports, you're typing reports, it's hard to have a mastery of all these terms. So what we did was we actually went through the BI-RADS and said, what's critical for actually determining management? And so we came up with condensed BI-RADS, which was developed by Ugandan radiologists and sonographers. And again, it takes into account that 100% of people performing ultrasound are not specialists. It's a binary system, so it's easier to use consistently and accurately. And it's a template. So if a patient comes in, the sonographer really just has to go through and circle if there's a mass, whether it's oval, round, or irregular, circumscribed, not circumscribed, hyperechoic or not hyperechoic, and that can determine whether you do clinical follow-up, imaging follow-up, or biopsy. So in 2016, the Ministry of Health in Uganda said you can use either one, but you have to pick which one. So you can't use made up words. You can't use a different system. You can use condensed BI-RADS or you can use BI-RADS. And it became standard of care. And we're using this to help improve breast ultrasound accuracy in Uganda. So we've been doing medical audits. The latest one was done in 2022 and we're about to publish it. And it shows a dramatic improvement in patient care as well. So here's an example of the case. Here's the mass that we found, and we're going to go through the BI-RADS, and so that's irregular because it's neither round nor oval in shape. It's parallel, so its long axis is wider than tall. It's spiculated, so its margins are spiculated. You can see that here with their kind of razors. They look like little teeth coming out. It is hypoechoic. That's a mistake. It should be hypoechoic. And there's shadowing. So you see beneath the mass, it's darker than in the adjacent breast tissue. So then vascular, which I'm not showing here, is present. And so I would give this a category 5, highly suggestive of malignancy. So it's greater than 95% chance of being a cancer. Now compare that with the condensed BI-RADS, and you'd say that the mass is irregular, not circumscribed, not hyperechoic, and then because you're in the bottom row, it denotes highly suspicious characteristics, and so you'd choose to biopsy it. You can decide which one's easiest. We have the resources to support both systems. Both can be templated. This is much cheaper though, because this just takes up a little piece of paper. So what is a BI-RADS assessment category? These denote a level of suspicion or likelihood of cancer and how to manage it. And I'm going to go through each of these categories in a little bit more detail, but I just wanted you to see them together. Now going to the condensed BI-RADS, you can see that whether it's category 1 negative, category 2 benign, the result is the same. You just go back to screening mammography or go back to not worrying about it. So they can go back to their community and continue working unless their symptoms get worse or they have new symptoms, they don't need to be seen again. Similarly, category 4 and 5, whether it's suspicious or highly suspicious, you're still going to do a biopsy. And so does it make sense to have all these different categories? Well, truth, it does matter if you need a nuanced view of it, but from a sonographer's perspective, it doesn't matter because you're not going to be doing the biopsy. You're going to be sending them somewhere else to do the biopsy. And so what you're using ultrasound to do is, does this woman need to go in and have a biopsy? can I follow her with my ultrasound at 6, 12, and 24 months, or can they just go back to their communities and not have follow-up? So category 0, typically we do not use for diagnostic exams. It's usually used for screening, but it is used to say that I need more images. Either we need priors to compare to, or we need a mammogram or something like that. 1 and 2, if you just say a normal exam or no abnormalities, there's no findings described, then it's BI-RADS 1. If you describe something like a lymph node, a cyst, or post-surgical changes, then it becomes BI-RADS 2. So even though the lymph node is normal, if you actually describe the lymph nodes as being normal, then it becomes BI-RADS 2. If you just ignore them because they're normal, then it's BI-RADS 1, even though it's the same exam. BI-RADS category 3 is probably benign. It has a less than 2% risk of malignancy, and typically for ultrasound, you're using it for oval circumscribed masses that are iso or hypoechoic, and you follow them at 6, 12, and 24 months. The idea is that these are certainly almost always a fibroadenoma, but not always. So they need to be followed, and if they grow 20% or more, they need to be biopsied. If they don't grow or they stay within a certain range of size difference, they can be continued to follow safely. Category 4 has a 2 to 94% chance of malignancy. And if any of the findings, usually masses, that have 1 or more suspicious descriptors, which I'll go into in a little bit, they become category 4. 5 is a greater than or equal to 95% chance of malignancy. And really we use this because we want to identify lesions that are so suspicious that after a biopsy, if it comes back benign, we don't want to accept benign. We want to continue trying to find out what it's caused by. So this distinction is very important for places that do biopsies and follow up on biopsy results, but in the front lines, it's less important because you're just using it again as a triage of whether the patient needs to go in for a biopsy. Usually they have to travel far distances away. And so that distinction becomes less important. BI-RADS 6, which is known biopsy-proven cancer, we typically don't use that except for in the tertiary care setting when they're being followed up for a neoadjuvant chemotherapy, and the oncologist wants you to decide whether the chemotherapy is being effective and the mass is shrinking or getting bigger. Okay, so there are 3 things we look for on ultrasound, and this is the ending of my talk, but this is, I want to make sure that people understand particularly masses. So we're going to go over in a little bit more detail the masses and how to describe them. So just to review, masses are space-occupying lesions that are seen in 2 different planes, and they must be distinguished from normal anatomic structures like fat lobules and ribs. So this is a actual question, is this a mass? So if you look at it, it looks like a space-occupying lesion. Now, some of you might be looking at the picture to the left and saying, aha, wait a second, you told me that, in fact, these suspensory ligaments should not be going up and down the image. They should be more flattened. That means that you're not pressing down hard enough, and you're absolutely correct. That should be the first clue that this may not be a mass, because the suspensory ligaments are not flattened out. They're actually going parallel to the ultrasound beam. So when you see this, the first thing you should do is actually press down. And you can see that with added pressure, this flattens out like a fat lobule. So this goes to technique is very important when you're doing interpretation. Okay, so we describe masses by shape, margins, orientation, echo pattern, and posterior acoustic features. Shape is, we use the abbreviation ROI, which is round, oval, and irregular. In the BI-RADS lexicon, we have round shown here in the left-hand figure. It looks like a circle. Oval, which is like an elliptical egg-shaped mass. You can have up to 3 gentle lobulations, and irregular is something that's not round or oval. In the condensed BI-RADS, we have irregular and oval round. So oval round is one term, and the reason we do that is because if it's irregular, you know at that point it needs a biopsy. It doesn't matter what the rest of the exam shows. It's irregular, it needs a biopsy. But with round or oval, you need more information because it could be a benign mass, probably benign mass, so you could follow up by imaging, or if it had other suspicious features like its margins or its echo pattern, then you'd choose to biopsy it. So margins, we use CAMUS to help remember all the different options. Circumscribed, where you can see the boundary of the mass or lesion as being very sharp. You know exactly when it ends and when the tissue starts. Very sharp. That's circumscribed. And when you see that, it could be a probably benign mass. It could be a suspicious mass. You don't know. You need more information. Compare that with the suspicious features of indistinct, angular, spiculated, and microlobulated. If you have one of these terms to describe a mass, it just gets a biopsy. And so what we've done with condensed BI-RADS is just use the BI-RADS term not circumscribed, because if it has any of these features, it doesn't matter whether you call it angular or indistinct, it's still going to need a biopsy. So we're just using not circumscribed and ignoring the fact that there's actually 4 different margins under the not circumscribed. So just briefly, indistinct, here is circumscribed. You can see how sharp the margins are. Whereas indistincts, you don't really know where this mass ends and where the breast tissue starts. It's very shaggy. It looks very spotty, and that's indistinct. Angular in the up left corner is the sharp corners coming out. Microlobulated are these little tiny bumps on the edge. And I hope you can see my mouse cursor. And then spiculated also has, similar to the angular, they have these like sharp edges, but you can see that in addition to that, they have these lines extending out from those sharp corners, and those are spiculations. But again, you can decide whether or not you use these 4 or use not circumscribed. It doesn't matter. What does matter is that if you use these terms, you recommend a biopsy. Orientation, long axis parallel to the skin, wider than tall is another term that gets used a lot. This denotes that it's growing along normal tissue planes. However, most cancers are parallel. So using a parallel descriptor is less useful. Whereas not parallel it's vertical. It is a suspicious characteristic, and it denotes that there might be a growth across tissue planes. The reason that this is not included in the condensed BI-RADS is that a lot of this is technique oriented. So you can imagine that in circumstances where the mass is parallel, to the chest wall, if the chest wall is at an angle, it can make a parallel mass look anti-parallel or not parallel. And because of that, we chose to exclude it from the condensed BI-RADS. So the question comes up, well, then how can you, what happens if an oval circumscribed hypoechoic mass is present that's not parallel? Well, if you look at this mass, the margins here are actually not circumscribed. So they have indistinct margins here. And so this mass right here would get a biopsy because of its indistinct margins. And the fact that it's not parallel is irrelevant in this case. So echo pattern. Echo pattern is, again, there's a lot of options. So there's hyperechoic, which is brighter than breast fat. There's hypoechoic, which is darker than breast fat. There's isoechoic, which is equal to breast fat. Whoa. There's heterogeneous, which has some bright areas, some dark areas, and some isoechoic areas. There's complex cystic and solid, which has some black areas from a cyst and some solid components. And sorry, there should be another line here because anechoic is separate. We only use anechoic for cysts. And so we typically don't describe something as being anechoic because we only use it for cysts. So if we say it's a cyst, it implies that it was anechoic. And so even in using BI-RADS, we don't typically use anechoic. And condensed BI-RADS, we don't use it either. We just call it a cyst. But it's important to know that what anechoic is, it's completely black on the inside. The reason that not hyperechoic are these four heterogeneous, isoechoic, hypoechoic, and complex cystic and solid is that they don't help you decide if something's benign. Whereas hyperechoic, if it's uniformly hyperechoic, that's a benign characteristic. And so because it's hyperechoic here, it's round, it's circumscribed, that can be dismissed. That's a BI-RADS 2 mass caused by fat necrosis or a lipoma. Whereas not hyperechoic masses, you need a little bit more information. Finally, posterior acoustic features. You have cysts and solid masses for enhancement. This is a cyst, so not necessarily helpful. In some cases, if you see something that's completely anechoic and you see the enhancement, you can be confident it's a cyst and just call it a cyst. If you see shadowing, that denotes a level of suspicion. It can be seen in fibrosis and cancers with desmoplasia. You can also have combined or none. Again, we did not include this in the condensed BI-RADS because if there's posterior acoustic enhancement and it's anechoic and there's circumscribed margins, it's a cyst. So we don't need to describe it. We just call it a cyst. Okay. So I wanted to go back to one of the questions earlier and show the importance of center frequency. So you could see that there's a very small area here, and you might wonder, is it a mass or is it a cyst? And this goes back to the resolution, so axial resolution. Increasing the high end frequency allows for you to resolve that this potential mass is actually a cyst. So this is 7.2 megahertz on the left and 14 megahertz on the right. And you can see that it's so much more nicer. Actually, I'm not even sure that's a word, but it looks more beautiful that this is a cyst and you can let this go. But on the left at 7.2 megahertz, you can't really tell that that's a cyst. So hopefully that makes things clear. Okay, then there's associated features. This figure shows a lot of them. So it shows skin thickening, which you'll first see that you don't see that white line that we talked about. Sorry, I'm not sure what's happening. You don't see that white line at the base of the dermis. In fact, you can't even tell where the dermis ends. Those black lines crossing through the fibroglandular tissue and adipose tissue is edema. You can't even see Cooper's ligaments here. And there's skin irregularity. Again, you can't see where the skin ends. So this can be seen in inflammatory conditions like inflammatory breast cancer, infections. And typically how you'd manage this is you give them antibiotics to see if this ended, this helped, and then you can decide whether or not this patient needs a biopsy. If it does not completely go away, the patient's going to need a biopsy. Calcifications, uncommon to see with ultrasound, but you can have them in masses, in tissue, and in ducts, and here are 3 examples. Top is a calcifications in a mass. You'd biopsy this mass because it's irregular and microlobulated. The calcifications outside the mass, I'm not sure most people would see these. Very hard to see. And then intraductal calcifications, you can see there the bright dots that are sitting inside the ducts. Those are calcifications in a duct. Special cases, this is the last part. I wanted to go over cysts. This is a simple cyst. It's round or oval. It's circumscribed, anechoic. It has post-acoustic enhancement. You don't need to do anything to these. These are benign. If you see all these characteristics, you can just call it a cyst. You do not need to describe it. Here is a complicated cyst or a cyst that has debris. So instead of being anechoic, it is actually hypoechoic or isoechoic. But when you actually move it, you can see it form like a snow globe or the debris inside swirling around. If you can see it, the debris being mobile, you don't need to do anything about it. It's BI-RADS 2 for a cyst. But if you can't tell, it looks just like a mass, you may need to actually stick a small needle in there and aspirate the fluid out or biopsy it. Here's an example of what that looks like. When you shake the cyst, you can see this debris, moving around. Hopefully you guys can see that. When you see that, you can call it BI-RADS 2. This is a cyst. And I have to thank my colleague, Diana Lamb, Dr. Diana Lamb at the University of Washington for sharing that with me. It's one of the most satisfying things to see in breast imaging, in my opinion. Cluster of microcysts, you can see that these are little tiny anechoic areas separated by septations. They have very thin intervening septations. And there's no discrete solid component. If there's a solid component, you have to treat it like a mass and biopsy it, but otherwise you can just let it go as a cluster of microcysts. Now, complex cystic and solid masses are not cysts. And I want to make sure that this point is very clear. Because of the solid component, it is not a cyst. It is a complex cystic and solid mass. These are BI-RADS 4. And these should get biopsied, and you should biopsy the solid component, not the cystic component. So if there's a dominant cystic component and a dominant solid component, then it is a complex cystic and solid mass and needs a biopsy. This is why some masses get biopsied and it comes back as debris or cellular debris and they get dismissed. It's because the palpation-guided biopsy didn't recognize that there were different components in a mass, and the needle went into the path of least resistance, which was the cystic fluid, and no solid component came out, and it was incorrectly diagnosed as a cyst or something benign. So targeting the solid component under ultrasound guidance is the preferred method to make sure that this is accurately sampled. There's skin lesions here. Skin lesions can be within the skin, or it can actually be subjacent to the skin. If it is within the skin, like shown in the top figure, you can BI-RADS to this and say it's a skin finding. These can become infected. The patient will need antibiotics, but you shouldn't biopsy this. Because all that bacteria and oil gets through the skin tract, or the tract of the needle, and it becomes infected, and it's a harder infection to treat. If it is subjacent in the skin, as shown in the bottom figure, you need to show that there is a tract extending to the skin surface, as I have with my white arrow there. If you do not see that, it has to be treated as a mass, and unfortunately, that means you have to biopsy it, and sometimes the patient will get an infection. So if you see a mass in that pre-mammary area, it's important just to tell the patient, hey, this might be a skin cyst, but we don't clearly see that tract going to the skin, and we're gonna have to biopsy it. If it is a skin cyst, we'll know because the cyst, it'll be like popping a balloon. The oils and stuff will come out your needle tract, and you might have an infection and need antibiotics treatment. But sometimes that has to happen if you can't demonstrate that that tract is present, because cancers can look like this too. Lymph nodes, morphology trumps size. So a lot of people try to measure the cortex, but there's not really a good cutoff for size. It's really a gestalt. This is a normal lymph node that has a fatty hilum, has very crisp cortical margins, and so this is called normal. These are examples of abnormal lymph nodes. On the left figure, you see that there is focal cortical thickening. So the lymph node has a standard size here, but then for some reason, one part of the lymph node, the cortex, is enlarged. This is suspicious, and as many of you are probably rightfully thinking, that if you were going to biopsy it, you would target the thickened part right here to find out what's going on. This is concerning for cancer. Inflammatory conditions typically do not do this. So focal cortical thickening is suspicious. Here is just standard lymph nodes that are enlarged. Many, many things can do this. Tuberculosis can do this. COVID can do this. And so if you choose to biopsy them, it's you know, when you're making that decision, you might choose to look at the other armpit. And if you see that their lymph nodes look the exact same, you probably shouldn't biopsy these. You probably should send them back to their primary care provider to have a workup. And if they can't find anything wrong, like tuberculosis or COVID, then they might ask your help to biopsy these to rule out lymphoma. Finally, there's a lymph node here, and you can see that the fatty hilum is there, but it's not as crisp and clean as it is on the normal lymph node here. Also, look at the edges. The edges look very irregular. So this one has indistinct margins, and this is a metastatic lymph node. Thank you for attending.
Thank you to Prof for that wonderful presentation. We have a couple of questions. We'll start, we have both from the chat and also the WhatsApp group. There's some members who couldn't really get it like through the chat due to IT issues. So first we'll start with Joyce. Joyce is asking about description of longer than wide. Can that be used to describe benign and malignant tumors?
Yes, actually, it better to use parallel and not parallel because those are a standardized lexicon. And parallel, when you use it, it can be used to describe both cancers and benign masses. Not parallel denotes a level of suspicion. So if you use not parallel, your recommendation should be to biopsy.
Okay, thank you. Then Topista from the WhatsApp group, she's asking how to differentiate a galactosile from pregnancy-induced cancer lesions.
Galactosile?
Yeah.
Good question. So galactoseals are made up of breast milk, and so they have fat, which is an echogenic debris. And unlike the cysts example I showed you, where the debris is following in the dependent portion, the breast milk and the fat float. So if you see echogenic, which is bright material in a cyst that's floating, that would be a galactosele. And in cancers, it wouldn't be that clear. So there might be some echogenic stuff, but it wouldn't be at the top. It would be in the side, and it would be not a straight line. Another way to tell is repositioning the patient. So if you have the transducer on the breast and you see that milky echogenic debris on top, tilt the patient a little bit. And if that line stays parallel to the floor, then as you reposition the patient, then that is a galactosele. A cancer is not going to change based on how you position the patient.
Okay, thank you. So she goes ahead to ask, is it correct to categorize a small lesion found in a dilated duct as BI-RADS 0 when galactography is recommended?
Typically, if you're recommending another study, you should come to a conclusion based on the ultrasound in centers that don't have mammography available. And so if you see something like a mass inside a duct, you would give it a BI-RADS 4 and recommend ductography for further evaluation and biopsy. And it's possible that when they do the ductography that they could wash out what looked like a mass, and it was just debris, and then it would become a BI-RADS 2. But initially, you should try to come to a conclusion of BI-RADS 4, and then recommend a biopsy, because the alternative is, what do you do if the ductography is not successful? Then you have a BI-RADS 0 that's sitting there, and you typically don't want to leave BI-RADS 0s hanging without a conclusion.
Okay, thank you. And most Vitas is asking, most of sub-Saharan Africa uses ultrasound. 95% of women in Uganda, where there is one mammo machine, he's talking about 95% in Western Uganda, where there's one mammo machine for 8 million population. How can we improve the use of ultrasound to increase sensitivity and specificity while reducing false positive rates, especially using BI-RADS, since it's also poorly utilized, mixing terminologies, creation of words or descriptions, because ultrasound is operator dependent and quality resolution of the equipment. Is there any AI, artificial intelligence tool to help lesion characterization?
Those are all excellent comments. I think practicing using BI-RADS appropriately, it will improve your sensitivity and specificity and patient care. There are AI tools to help with lesion characterization, but they're expensive. And we are currently looking at options to for a low-cost ultrasound machine that would take out some of the operator dependence for characterizing, but that's currently in the testing phase. So it really is just practice, practice, practice. Following up on your outcomes. So if you recommend biopsies or you recommend not biopsying, keep track of those patients and follow up with them to see, hey, is this, would the biopsy come back as, oh, it wasn't cancer? Okay. And then write that down so that you start to developing quality improvement.
Okay. Yeah, so still from Vitas, through Ultrasound Africa, may we seek collaboration for materials besides the webinars to help in understanding of lesions, characterization, and also improve our reporting while we minimize anxiety due to our reporting pitfalls. Otherwise, thank you, Prof, for this wonderful refresher content and material. Welcome back to Kampala. So,
I'll see you guys in January. So yes, so I think what we did last time we were there is we printed out the condensed BI-RADS forms that people could take with them. And then I gave a practice, like just cases where people would come and I would show, I think I had like 100 ultrasound cases and they would use those forms and they would fill them out as if they were interpreting it. And then we would go over it and then people could ask questions. And I think those provide sonographers and radiologists confidence building exercises where they're like, wait, I could do this. And we have great research showing that when using condensed BI-RADS on those forms, even people with very little experience were getting to the right answers most of the time. And so I think those exercises are very helpful in gaining confidence.
Okay. Yeah, we have hands up. Bilal, your hand is up. You can unmute and ask the question. Bilal, are you there? Okay, Bilal, if you can, then we have Prince Habe. Prince Habe, you can go ahead and unmute yourself, then ask the question. Okay, so if we don't have any other questions, members, it's about time. So if we don't have any questions, we would like to thank Professor Scheel for this wonderful time given to us. And would like to let you know that we had like a great number of people all the way from West Africa up to down to South Africa. We had attendees from Nigeria, Ghana, Zambia, Kenya, the Horn of Africa, Somalia, Eswatini, Zambia, South Africa. So we really had a great team, and also from the United Kingdom, we had attendees from there. So Professor Scheel, we are really so honored to have you, especially that October is a breast cancer awareness month. And it's good to know that now this presentation was all about breast ultrasound. And we're also happy to let you know that we had some of our mentors on the group. We had Professor Kawaya on, we had Dr. Zerida, and other members from Rwanda. So it has really been a great presentation, and I believe many people have really benefited from this. We believe in the future, you still honor our invite in case we invite you for any presentation, and you're always welcome to share with us. There's another question still that I'd missed out. Someone is asking, how would ductal papilloma show on ultrasound? Maybe you could go to that.
A papilloma?
Yeah.
So papillomas typically are complex cystic and solid masses. They appear either as a mass sitting inside a duct, but oftentimes they just look like a mass with fluid and with a solid component.
Okay.
I also see a picture. Can breast sucking improve breast cancer chances? Chances in getting breast cancer or improve chances of curing breast cancer? Depending on how you interpret that question, but the answer is no for both. So breastfeeding reduces risk of developing breast cancer. If maybe that's what you're asking, then that's true.
Okay. Thank you. So someone is asking, thank you, Prof. How do we access the slides? Members, these slides will be shared, or this presentation will be shared on our YouTube channel, Ultrasound Africa. Still, you can go and visit our website, that is www.ultrasoundafrica.org. We always upload these presentations. And still in the chat, you can join our WhatsApp group at Ultrasound Africa. The link is there. We have another question. Thanks a lot, Prof. Do we still grade breast edema using the BI-RADS system? And if so, which grade does it qualify? Thank you. That is Dima asking.
That's a good question. So breast edema is an associated feature. And so if it's just edema, it would be BI-RADS 2 typically, because you wouldn't biopsy breast edema. They would need a clinical follow-up. Typically, though, what we end up doing is if the patient's history is sounding like it has an infectious process, we would give it a BI-RADS 3, have them go on a trial of antibiotics, and have them then come back for repeat imaging. Because what happens is that the edema, if it's associated with skin changes, well, then we might be looking at inflammatory breast cancer. And so we want to keep them under surveillance. So we would have them come back in like 6 weeks, just to make sure everything's resolved. But breast edema can be caused by many things like heart failure, infections, and so usually it's not caused by breast cancer, but we just want to make sure.
Okay. Yeah, so we have Dr. Anyak. He's saying excellent breast ultrasound lecture. Thank you. And then we have, many people are asking about the presentation. Yes, this presentation will be shared on our YouTube channel. You just need to follow or check us out on our YouTube channel, Ultrasound Africa. And we have a hand up. That's Maxwell. Maxwell, you can unmute and ask the question. Maxwell?
Prof, thank you so much. Thank you so much for your presentation. I was asking if the breast scan, is it suitable to use a linear or a curvilinear?
Good question. Always linear. Always linear. And high frequency transducer.
Okay, thank you.
Dima, you can still unmute yourself. Dima, your hand is up.
Yeah, thanks, Professor. My question is, if you get someone having that, let's say breast edema, then with axillary lymph nodes, what will be the next step?
If there's edema in the breast and the lymph nodes are enlarged on one side or both sides?
On both sides.
Okay, so if it's both sides, then that suggests a systemic process. And you would want to work with your clinician to make sure that they had the appropriate clinical workup. If it's on one side, then you have to worry about having some type of cancer that you just are not seeing. And so it may be helpful to biopsy the lymph node, but you typically don't start with biopsying a lymph node if the lymph nodes are enlarged on both sides, unless they've already done a clinical workup and they're asking for your help.
Okay, so that's well answered. Do you have any questions? We have a few minutes to the close of this. Kindly, if you have a question, just ask or type in the chat. As you are waiting for any questions, I still remind you that at Ultrasound Africa, we have various activities which we offer, and these include education and training, continuous professional development. We also deal in research, accreditation, certification, and protocol development. Then also we do once in a while outreach programs. So you're always a wonderful team, and since we have a team all over Africa and our friends across or other contents, we always welcome you for these activities. So if we don't have any questions, allow me to join you all in thanking Professor Scheel for having this very wonderful presentation to us, and we're looking forward to always having you in the future. Thank you.
I look forward to my return. Have a nice day, everybody.
Same to you. Thank you.
Thank you.
Thank you, members. Remember to go to our YouTube channel and our website to check for future activities coming up. Thank you. You've been a great audience. Nice weekend.